Welcome to our 12th IANS seminar, um, Multidisciplinary Management of Anal Cancer Down Under, a powerful team approach. We are joined by Dr. Nigel Barwood, Dr. Serena Sia, and Ashley Murray. Dr. Barwood graduated from UWA with honors in 1991. He is a general surgeon. He was awarded the FRAC in 1999, and his fellowship years at the Royal Infirmary of Edinburgh and Melbourne, both as part of the CSSANZ post-fellowship colorectal training program. He's in Perth right now as a colorectal surgeon at the Fremantle Hospital and in private practice at St. John's of God in Murdoch, where he is currently chair of the multidisciplinary colorectal team and a past head of the department. Ashley is a colorectal clinical nurse specialist with stomal therapist. She earned a bachelor's degree, postgraduate certification in rheumostomy and continence, currently studying for her master's as a nurse practitioner, which will be due in July. I'll abbreviate this a little bit so we have time to finish. And Serena Sia completed her medical degree at the University of Western Australia in 1993. She undertook specialist training in radiology oncology at Royal Perth Hospital and Sir Charles Gardner Hospital, as well as the Alfred Hospital and Peter MacCallum Cancer Institute in Melbourne. Serena is the head of the Department of Radiation Oncology at Fiona Stanley Hospital, as well as the Gynecological Radiologist Oncology Unit in Western Australia. These three people are coming to us from tomorrow, which is Monday. So I know that the time difference has confused everyone, but we hope that people will enjoy this seminar. If you have questions, please put them in the chat. The seminar should last about an hour. And if you want to give us the first slide, that the medical slide, Audra. So this presentation is not intended as a form of medical advice. No material presented are intended as a substitute for professional advice, diagnosis, or treatment. Always seek guidance from your medical or healthcare providers before undertaking a new healthcare regimen. And actually, since we started on time, Audra, can you pull up the in-memory slide? Is that possible? We always honor someone, and this seminar is in memory of Carol Ann McAllister, November 11th, 1945 to August 14th, 2024. Her husband sent us this lovely picture of her and said that Carol led a life marked by intelligence, empathy, and an unwavering sense of practical wisdom. I knew Carol from our University of California, San Francisco support group. So we are dedicating this seminar to Carol. Okay. Nigel, I think.
Oh, we've got some slides happening, Audra. There you go. Okay, that might go a little bit bigger. Are we going there? Oh, there we go. Good morning, everyone, or good evening or good afternoon, depending on where you are in the world. But welcome from Perth, Western Australia. Just in case you're wondering where we actually are, I'll give you a few introductory slides. And apart from being a colorectal surgeon, I'm a competitive sailor on the weekend, so I thought I'd tie that in a little bit to the introduction. We change slide, please. Right, so if you look at the map of the world, particularly according to America back in the 1980s, Australia was this mysterious place somewhere down under which didn't really exist on the map. Just change slide, please. The USA had held the America's Cup for 132 years, which is the longest winning streak in world sporting history. And at the same time, Australia were at an all-time low in sport. We're a proud sporting nation and we're pretty useless. And we needed some heroes. And instead, we got these 5 rather unusual looking guys from Perth up on the right there. And they built Australia 2, the yacht. And you can see down the bottom there, that's it being wheeled out of the boat shed, which nowadays Serena and I go and buy a very expensive food from. It's now a food store. And Australia 2 had its famous wing keel, and there was the boxing kangaroo flag and the song Down Under. Change slide, please. And these guys from Perth went over and took on the might of the New York Yacht Club and came back from 3-1 down to win 4-3, which was a great moment for Australia and particularly for Perth. Just change slide, please. And amongst all the celebrations, you've got pictured there, that's actually our Prime Minister, believe it or not, who at the same time held a Guinness World Record for beer drinking. And he was widely quoted as saying that any boss who sacks somebody for day to not turning up to work that is a bum, which I think translated into American means an ass or a butt. And I had to point out to my son down the bottom right here that this is actually up in neon lights in his workplace. So it's quite a famous saying. So that's sort of when Perth entered the map in the eyes of the world. And that sort of starts us on the journey of anal cancer. So next slide, please. So lovely lady Donna has agreed to let us present her case. So she's a 40-year-old, very fit and healthy lady who back in 2019 was referred by her primary care doctor, and I had a good look at the referral and it looked really much like just sort of a usual case of hemorrhoids. Described some bleeding and prolapse, and she'd had a colonoscopy only a couple of years ago, so you'd look at that and think it's not going to be anything much, but fortunately we got her into the rooms fairly promptly, and when I examined her in the office, she had a mass and got her in straight away for a colonoscopy and did a biopsy and also arranged a PET scan. So I'll just change slide there. So she then went up for multidisciplinary team discussion, which we'll talk about in a minute. And if you look at the bottom left image there, you can see that tumour, which is just inside the anal verge. So the biopsy came back showing an anal squamous cell carcinoma, so a typical sort of anal cancer. And the PET scan images there are on the right, and you can see some sort of white activity where the tumour is, and there's a little lymph node, which is pretty hard to see in the lower image there with the circle around it. So at that point, what we would normally do is just treat her with chemoradiotherapy, but her tumour was a bit unusual and it was very easy to excise, and she was very keen on this. So we actually excised the tumour transanally. So it's just a simple operation to remove that, just stayed in overnight, and then went off to Dr. Sia for chemoradiotherapy following that. So I'll just flick over to Serena to continue on the story.
I think it's coming over to me.
Ash first, then Serena.
So I'm just going to get mine. Everyone see that screen? See those slides?
Okay, now I'm ready.
Your slides clear?
Okay, so what I'm going to go through is our colorectal multidisciplinary team meetings, and I'll start a little bit about the hospital that I work for, which is St John of God in Murdoch. So we're a 511 bed private hospital. In Australia, we have private and public health. So we have universal healthcare that everybody can access through the government. And then patients have the option of having private health insurance if their budget allows for it. And they have the option of going through private health with that, which basically means they're referred straight to their choice of specialist and they get to choose what hospital they go through. So St John of God is a not-for-profit organisation, and my role was originally funded through a donation. And after 2 years was made into a full-time role and is now funded through the hospital. So in our multidisciplinary meetings, our aim is it's a collaborative approach to cancer treatment planning and ongoing treatment pathway care for patients. So our meetings run fortnightly, and we usually discuss 20 or up to 25 patients at each meeting, and who we discuss are basically newly diagnosed colorectal cancer and anal cancer patients. And we also go through ongoing surveillance with these patients as well. So looking at any ongoing scans and changes in their treatment. So the team consists of colorectal surgeons. Nigel is the chair. We have 3 colorectal surgeons, 2 medical oncologists. Serena's our radiation oncologist. We have a pathologist, radiologist, and me as the colorectal clinical nurse specialist. And sometimes we have an independent stomal therapist as well, but I am a stomal therapist. At each meeting, we present the patient's past medical history and what we're actually discussing at that particular meeting. And we discuss the patient's imaging and histopathology, and then we make a treatment plan for that patient. So the patients are to be presented usually by the surgeon, sometimes by the medical oncologist, and they present the patient and what we want to discuss. So my job, I liaise with all the departments, get all the imaging from multiple different imaging businesses all uploaded to the one system, and organising external slides, so all of the biopsies and big specimens, and getting it sent to the specific lab where our pathologist is. At the meetings, I take notes on what's been discussed and I write outcome letters. So the patients get a copy of this letter which goes through what we've discussed, and it's also sent on to their general practitioner and their oncology team, so everybody knows what's been discussed and what the recommendation from the meeting is. So ideally, every newly diagnosed patient is presented at the meeting before we start any treatment. And we also discuss precancerous patients as well, who've been referred through by the sexual health specialist who does the high resolution anoscopy as well. So the aim of the multidisciplinary meeting, the aim is to ensure that the members of the treatment and the care team can discuss all relevant aspects of a cancer patient's physical, psychosocial needs and any other factor that's going to impact on the patient's care. So multidisciplinary approach, it assures that we have improved treatment for the patients, improved team communication and support so that the patients know, so that everybody in the patient's team knows what's going on with them, improved coordination of the patient care, reduced service duplication, so we're not doubling up on services, increased opportunities for recruitment onto clinical trials as well, and consideration of patients' physical and emotional needs. And it is well documented and accepted that multidisciplinary care represents best practice in terms of treating, planning cancer care for these patients. So what my role is, I'm basically a cancer care coordinator for all of the anal and colorectal cancer patients. So I'm there at their first appointment with the surgeon. So when they're having first contact in that very high stress environment, they have me there and they get my contact details. I follow up at their appointments after the multidisciplinary meetings so that we can discuss the outcomes and what their treatment plan is going to be. That's when we're usually discussing if there's going to be any surgery, starting to talk about if they're going to be having radiation, chemotherapy, And so I'm talking to them about associated side effects and how to manage these issues. So skin related issues, any functional bowel issues, whether or not they're going to be having an ostomy. And so they have me there, as well as referring them on to any support services, such we have the Cancer Council, Bowel Cancer Australia here that do offer services for free for patients as well. I assist with appointment bookings and urgent imaging, pre-operative and post-operative education, stoma sighting, and a big thing is preventable readmissions that I do. So troubleshooting patients over the phone rather than them just coming straight into emergency departments. And support throughout their entire treatment and ongoing surveillance and survivorship. So referring them to appropriate support networks and allied health. So I have some patients who I first met, 3-4 years ago, who will still call me up to this day when they're having issues, and I'm there for them all the way through. So we'll go back to the multidisciplinary team and the discussion of our patient. So the patient was first referred to Dr. Barwood with the ongoing constipation and PR bleeding, and then she underwent the colonoscopy and the excision of the anorectal polyp. And then she was presented at our multidisciplinary meeting. So her histopathology, so her biopsies and her PET scan were both presented at the meeting. And our discussion showed that she had moderately differentiated squamous cell carcinoma with venous invasion extending into the resection margin, and it was P16 positive. The PET scan showed that the anorectal tumour was avid, which means that it had a lot of uptake on the scan, showing that it was cancerous, and we had an involved lymph node as well. And the recommendation from that meeting was that the patient was to have definitive chemoradiotherapy for cure. Okay, so we can go through to Serena now.
Let's see if I can do this. Screen 2. Got it? Can you see my slides?
Yep, we can see them.
Yeah, okay, great. Hi, I'm Serena Sear. I'm a radiation oncologist specializing in treating pelvic malignancies. And as you've heard, with the MDT, where the patients are discussed, by the time they get to me, I'm actually really au fait with everything about them, including all their scans and diagnosis, and which makes things so much easier. And with Ash's input into managing them as a whole person, often they arrive, to see me actually anticipating treatment and having quite a good understanding of what radiation entails. So that does make my job a bit easier. So look, the case study, Donna, she did come through an MDT 5 years ago. And as we heard, it's a T2N0 M0 tumor, T2 meaning tumor somewhere sitting between 2 and 5 centimeters in size. And the mesorectal node, we thought it was kind of ambiguous, but I'll explain to you that even in this setting, we always include the nodes when we treat patients. Of relevance in her history, being 40, she's nulliparous. The reason being that she had polycystic ovarian syndrome, which makes having kids a bit more difficult, and especially with the background of endometriosis as well. The other complicating factor, which is important in a setting of radiotherapy, is she's got a history of SLE as well. And when you're on SLE, you could be on various immunosuppressants, including methotrexate, Plaquenil, and she was on prednisolone. So all these do ring alarm bells for me as a treating physician, because it does radiosensitize, which makes side effects and potential complications of radiotherapy potentially more likely. Doesn't mean it'll happen, but connective tissue disorders do make radiotherapy side effects more prevalent. So all really important factors to know even before starting treatment. Her being nulliparous at 40 is of some relevance, because, as I'll discuss later, with radiotherapy affecting ovarian function, that will render her infertile. So really important factors to discuss before we even contemplate treatment. I won't spend too much time, but just want to point out a few things. Anal SCCs are rare, but interestingly, the incidence is rising globally due to HPV infections. And we've got a really good HPV vaccination program, and I think the US does too. But I can see more recently, Japan's withdrawn their HPV program, a vaccination program, due to concerns about some of the side effects of vaccines. So for that reason, perhaps that could explain why the incidence is rising, because like cervical cancer, you expect it to be falling, not rising with the vaccination program. But anyway, just to point that out. And the other thing to remember is with anal cancer, although rare, most present with non-metastatic disease. So most are very, very curable. And the optimal management, as you've heard, is a combination of chemotherapy and radiotherapy. With mitomycin and 5-FU, sometimes capecitabine can be used instead of 5-FU. And my talk is mainly focused on radiotherapy and advanced radiotherapy techniques. You've heard of IMRT, VMAT, potentially. VMAT stands for volumetric arc therapy, and it's sort of the more advanced version of IMRT, which is intensity modulated radiotherapy. You don't need to know much about this other than the fact that it's a really sophisticated delivery program which aims to give very conformal radiotherapy while sparing normal tissue. I'll show you some pictures on that. Just quickly, future directions I'll mention very briefly. Chemoradiotherapy is the standard of care, but more and more we're looking at immunotherapy and how it can be incorporated more so in a metastatic setting, and possibly trying to de-escalate treatment for very, very early cancers. And that's where perhaps surgery alone could be considered. And Nigel may touch on that, but generally chemoradiotherapy is still the mainstay for now. So with Donna, this is actually her prescription. How do we do it? Evidence would suggest that a dose between 50 gray and 54 gray would be the standard of care. Dose escalation studies looking at going up to 60 gray hasn't really shown a survival advantage. The 45 number here is to treat bits of her that's not involved based on imaging or clinically, but rather to treat it electively. So lymph nodes are an important site that could be harboring some subclinical disease that's not clearly evident on imaging. So that's her dose prescription, 50.4 gray to the primary and less to the nodes. And in our treatment plan, this is what we look at. We'll try and maximize the dose to the tumor whilst reducing dose to bowel cavity, femoral heads, genitalia, bladder, iliac crest, and I'll explain that in the context of the toxicities when we talk about that later. So treatment planning, just very quickly, her journey would start at the radiation stimulator, which is a mock-up of what her treatment would be when it comes forward. This is the planning system. So once the scans are done, it's fed into this planning system, which is where I'll volume her treatment, and then we'll come up with a plan that delivers what would be optimal for her anatomy. And then the treatment linear accelerator is this thing. It's a device which basically delivers high dose conformal radiotherapy to whichever site we elect to treat. So pictorially, that's what we've got there. So her treatment itself, if you look at, these are some selected slices of what's being treated. So her primary would be, this is her accessoral slice, looking at the primary would be roughly here in the anorectal junction. So this whole bit gets 50.4 gray. The elective bits, which is all the lymph glands, is getting that kind of darker blue bit, 45 gray. And you can see that we always include the inguinal lymph nodes here electively, and then that's the primary here. And that's what it looks like when you look at her face on. Treatment 6 weeks long, typically Monday to Friday. That's a typo there. It's back in October 90 to December 2019. I don't know how it flipped onto 24, but so it's a 6-week period. And one thing really important for patients to appreciate is that it can take up to 6 months to achieve a complete response. So really important in follow-up that the surgeons and us see her 3 monthly, 6 monthly to make sure it goes away before we consider any salvage or rescue type treatment. So never over react when there's still tumour seen, possibly at that 3-month mark. Okay, so down to side effects. So once all treatment's completed, what are the side effects we can expect both acutely and late? Acute side effects by definition is anything within 3 months of treatment, and late anything kind of 6 months and beyond. And during treatment, definitely a little bit of nausea, a bit of fatigue, diarrhea is quite common. Low blood counts mainly from the chemo. Skin reaction, this can be quite nasty, especially if they're very low lying, because we do include the anal sphincter when they're very low lying, and that can cause a lot of moist desquamation, which requires quite a bit of skin care. Sometimes SSD creams, a lot of salt baths, and could take up to 6 weeks to truly recover. By proximity of these structures, you know, that the rectum can get inflamed, so proctitis is common. Cystitis and urethritis and vulvitis is all kind of around that area, so passing urine could sting a bit, and frequency and dysuria is certainly quite common. But we expect all these symptoms acutely to settle really within 6 weeks to 2 months by the time we see them. Late side effects, these are the ones which would be good to mitigate in the longer term if we can. Some not possible, but others, to some degree, we can reduce the impact. So scarring over the perineal tissue, taking a dose of 50 to 54 gray can cause some anal scarring. It can sometimes cause mild fecal incontinence, and sometimes more severe, but generally the treatment outcome and functional outcome is still very good in these patients, and very rarely would they be needing pads, you know, due to fecal incontinence. Weakening of pelvic floor muscles, so we as general rule say keep doing your pelvic floor exercises just to improve, you know, both bowel and bladder control. Sexual dysfunction in females, maybe less so than males, because erectile dysfunction can be seen when we treat the pelvis to a significant dose. Vaginal dryness and stenosis, that's something that is quite common, and vaginal dilators would be something that we routinely prescribe to patients and encourage regular use. Menopause and at 40, unfortunately, that's a given because the ovaries are very sensitive, and the act of transposing ovaries at the age of 40 would in itself render them menopausal in most cases. Infertility, we talked about as a result of anovulation. Lymphedema, not too common, but because we treat the inguinal nodes electively, in some patients they could notice a little bit of swelling in the legs. Osteopenia, garlic crest and pelvic bony structures. With IMRT, VMAT technique, we do try and reduce the dose to the surrounding bones. Second malignancy, she is young at 40, so that's certainly something that we need to screen for, and we do warn them about it. The overall risk is still very small, but you know, it's got to be taken into account. And just as my final slide, the importance of follow-up. So once she's completed her treatment, so myself, Dr. Barwood, we've got our infectious disease consultant, Jenny, who sees her regularly too. In her case, she was also referred to the menopause clinic, which we've got a public and private sector services, and she was put on HRT. Physiotherapy, I don't think she had to see one, but certainly available for those who have lymphedema or any issues with the pelvic floor. And sexual rehabilitation. She is using vaginal dilators to prevent the scarring that we can sometimes see. And Nigel, I'll pass it on to Nigel, because regular rectal examinations, scopes and PET scans as part of a follow-up, and certainly HPV screen vaccination in younger patients could be of benefit in this setting. So back to you, Nigel. You're on mute.
Oh, I'm mute.
Yeah.
Oh, thanks, Serena. That was brilliant. So we'll just go back to the patient's journey. Got my slides back up there, Audra, hopefully.
Hey, could you, Serena, could you stop sharing so I can pull up the slides? Thank you.
Right. Maybe just go back one if you can, Audra.
Sorry.
Yeah, right. So that's good. So that was sort of where we finished before, and that's the PET scans. And so after she's had her treatment with Serena, the chemoradiotherapy, she's come back and seen Serena and myself regularly. She's had a PET scan each year. And just onto the next slide, please. Got the colonoscopy. Is there a colonoscopy one there somewhere? Maybe flip next one. Oh, no, back. Oh, there we go. Yeah, and that's just showing a couple of years post-treatment, she had a colonoscopy. And if you can see on the right there, there's a bit of blue ink, but there's absolutely nothing looking like tumor. So she's had a complete response. So at that stage, we'll be fairly confident that it's going to go away and stay away, but they all get 5 years of follow-up. Just onto the next slide. And Donna just last month finished her follow-up, so it's there. She's very happy. She's now cured of anal cancer, didn't need any major surgery, just predominantly the chemoradiotherapy, which is fantastic. If we can just flick back a couple of slides, please, Audra. Yep. So looking through the history of anal cancer, so back in the early days, the only treatment available was an abdominoperineal resection, which is a very major operation described in the early 1900s for rectal cancer. And it's sort of shown on the right there. And we basically take all the tissue out around the rectum and the anus, remove all the lymph nodes and everything, and the patient ends up with a permanent stoma on the left side of their tummy. And that really hasn't changed in over 100 years. The game changer with anal cancer was Dr. Nigro from Detroit, 1974, quite controversially reported 3 patients he'd treated with chemoradiotherapy, and all of them, the cancer completely went away and stayed away. I think 2 had surgery and had no cancer in the specimen that came out, and the 3rd one didn't want surgery and was cured anyway. So that completely changed how anal cancer was treated. And now you've got the Nigro protocol, which is pretty much exactly the same, I think, Serena, as it was 50 years ago, which is just absolutely brilliant treatment. And as much as it upsets me, I have to admit it's way better than surgery. And I spend most of my time telling the patients how fantastic chemoradiotherapy is, and their chances of needing surgery are very small, and that Serena and her team will sort you out and you're very unlikely need any surgery. So that's quite phenomenal that the treatment protocol's been unchanged in 50 years, meaning no one's come up with anything better. Very unusual in oncology. Just flick onto the next slide, please. Very occasionally we need to perform surgery for anal cancer, and as Serena alluded to, occasionally, if we're not quite sure whether it's precancerous change or very early anal cancer, we'll just perform a wide excision, so just through the anus, just taking out a local area of tissue without a stoma or anything like that, just probably more for diagnosis than anything else, but occasionally for very early cancer that might be enough. And then in selected cases where we either can't use radiotherapy, probably the most common one would be in a male patient who's previously had prostate cancer and needed radiotherapy and can't have any more radiotherapy because they've already had their maximum dose. They might need surgery, or in the very unusual patient where the cancer doesn't go away or comes back after Serena's wonderful chemoradiotherapy, they may need the old-fashioned excise the whole lot, sew up their bottom and give them a permanent stoma, which isn't a great operation, but it's a way of salvaging the occasional patient who needs surgery. Just onto the next slide. Oh, we've done that. Yep, done that one. And just a little bit more about the MDTs. So one thing in terms of cancer treatment that we're quite lucky with in Perth is that we've got almost 3 million people, and almost all of them live in that little bottom corner, the bottom left-hand corner, the southwest of our state, and 80% of our population live in Perth. So we're very centralised. And despite having a huge state, and our state's 4 times the size of Texas and bigger than Europe, so we're an enormous state, but everyone lives in the one spot. Whereas you look at the US, and that's the population scattered all over the place. So it makes centralisation of services a lot harder. Just onto the next slide. So our MDT started 5 years ago when we finally got Ash, our super colorectal nurse, who's also a stomal therapist. And as she mentioned, there's 6 members of the team, which you can see in the photo there. And around Perth, we've got 8 colorectal multidisciplinary team meetings, and they're both in public and private practice, and some are in a bit of both. And as Ash mentioned, we'll discuss all of our anal and rectal cancers before they're treated. And going back to when I was starting out and doing my fellowship 20 years ago, some of the rural centres would still treat anal cancer with surgery rather than chemoradiotherapy. They were very behind. So the MDT is a very important way of making sure all the patients get the best up-to-date treatment. Just flick on to the next slide. So in Perth, we're famous for 2 things. One of them is Dr. Jenny McCloskey, who I'm sure you all know, who is a world expert in anal neoplasia. And just to wrap up the sailing stuff, so when I was at uni in 1987, that was my job during the uni holidays, working on a boat taking Americans out to watch the America's Cup defence. And of course, America won it back, and Australia hasn't been anywhere near winning it again, but it was great for a while. Thank you to everyone from the IANS for having us along. It's been an honour and a pleasure to present to you, and I think we're open to questions. Mary Jo?
Yes, that was excellent. I don't I don't know if there's any questions in the chat at the moment, but I am very impressed with the fact that when a patient comes in, they get all this coordination of care. That definitely does not occur everywhere. And I'm wondering if you have any ideas or suggestions about how that kind of approach could be implemented in other places. You know, one of the things with an international organization is everybody, you know, the reimbursement is different in different places, but that kind of a team approach just would be so lovely. And it also looks like Helen has a question, but that was my first question, and then I'll move on to Helen's question.
It's not an easy thing to do, Mary Jo, and it took us 15 years to get Ash. And the funding is often a problem. I think, as Ash mentioned, we were very fortunate to have a very generous cancer patient donate some money for a couple of years to pay for Ash, and then the hospital realised after that they really had to fund her as a full-time employee. So getting that through, I think getting the nurse in is the key, because Ash pretty much does everything and organises the whole patient journey, the MDT and everything. So it's not always easy to do, but makes an enormous difference. Makes our life easier and makes the journey and the treatment for the patient a lot better.
Boy, I can see that. Helen, you can unmute yourself if you want to ask your question. There you go.
Okay, sorry about that. So I'm trying to type my questions big. So I'm an admin in several anal cancer groups, and I'm also a member of the Australian Anal Cancer Survivor Group. So when I'm listening to the Australian anal cancer patients, you've got loads in this group, and I'm not talking about the IANS doctor group that's Australia, New Zealand. This is another one. So the things that I come across to answer, not just in the Australia group, and I'm in Canada, but access to proton. So you've only got the Bragg Centre, I think, which is one up better than Canada because we don't even have a proton machine. So I'd like to know your input as to what your feelings are for proton as a limiter of the acute and medium long-term effects. And then we're going to have the question of vaginal dilators during the radiation session and not just as a, in between and after. And also, for some reason, a lot of the Australian patients, there's a lot of posts that come up with the fact that they feel really isolated and, et cetera, et cetera. And even though I say to them, you know what, Australia has got some of the most cutting edge researchers and doctors dealing with anal cancer, tends to be Sydney, though I know Perth has got you guys as well. But I'm surprised that there's not more sort of knowledge in some of these Australian people that we're getting in the group. So basically that's a case of information's not being disseminated across the country to the various cancer centres, but which I can't believe. But anyway, that's what I seem to be getting. So those are my questions. So proton, vaginal dilator during radiation, and dissemination of information across Australia. And as I say, I am Canadian. I understand what it is to live in a mass continent with, limited access. And for our rural Canadians, sometimes they're a bit screwed because they have to come and live where they do. And yeah, so I'll let you answer those. And I like the questions that other people have just asked, some of which we've covered in other webinars, but that's good.
All right.
Thank you.
Thanks. Thanks, Ellen. Okay.
Hi, Elaine. I can take on the first two if you like.
Yeah.
So the Bragg Centre, which is awarded to Adelaide, in spite of Sydney, Melbourne, Perth wanting it. But anyway, there has been a delay in its opening, so it's not available in Australia as yet. But as a general rule, proton treatment, the idea of this Bragg pit, which I won't go into, but it's actually the way protons travel, and when it hits a target, it deposits all the energy in a very, very short distance. So it's perfect for spherical, small lesions that you can actually try and target with a very small fall off. So things like small brain tumor, spinal cord tumor, kids with, it's sort of typically useful for pediatrics. If something's close to the eye, we want the energy stop to be quick. And the prostate's not a bad one too, because it's spherical, central, and targetable. With something like anal canal cancer, where you want to treat inguinal nodes and pelvic nodes as well as the primary, we're no longer able to do something where you aim and stop suddenly, because you're actually electively wanting to spread that dose to include the nodal chain. So not so suitable for anal cancers. I haven't read otherwise. So that's the first question, hopefully answered. The second one, vaginal dilators. So I do a lot of gynae work as well, cervical and other cancers, but we tend to recommend dilator use about 4 weeks after completion of radiotherapy, because during treatment, the inflammation is just actually too uncomfortable. And generally scarring doesn't occur immediately. It tends to be a late side effect. So at that 4 to 6 week mark, when things have healed, that's when we recommend using the dilators, and up to 2 years in patients who are compliant. But the first 6 months is really important, because that's when healing takes place. I hope that sort of answers some of those questions.
Yes.
I can go into.
I was going to say, Ashley, I would like to hear your thoughts.
The patient feeling isolated. So I'm not sure how it works in the rest of Australia, but I know in Western Australia, the amount of time and the amount of patient touch points that I have compared to all the other colorectal nurses are quite different. I have had a couple of patients who've been at different tertiary hospitals and private hospitals who they've then been referred to us for some reason or another, and they've said that they've actually not sat face to face with their colorectal nurse. And so I think it really depends where you go for your treatment, and a big thing is private versus public. So the tertiary hospitals here, they're seeing a lot more patients, and so it's very limited what the colorectal nurses will actually be spending time with the patients, because it's more or less triaging patients, getting them in for their appointments and having that sort of thing. Whereas when, you know, you have a smaller amount of patients, you can have that more holistic approach where you can spend the time with them and go through all of those things. But I think it's also the fact of it's not just one cancer strain that we're dealing with. We're dealing with the colorectal cancers as well as the anal cancers, and the patients who are having ostomies do need a lot more time allocated to them. So I think that might be one of the things in Australia. And in regards to patients being isolated, here in Western Australia, we have something called the PATS, Patient Access Transport Scheme. So if they are coming from rural areas, the government actually funds them for travel and for accommodation. So we can have the patients access that if they're coming down here for treatment. The government will actually fund that for them, so they're not out of pocket for it. So obviously, though, if they're working up remotely, coming down, they're not going to be able to work, but at least they'll have there's accommodation that we can get them into, and the government will fund that as well.
One of the questions has to do with the significant after effects. And so, Ashley, are you the one who follows people in that way, or do you, and does the team meet, the multidisciplinary team meet again to speak of long-term effects?
Not normally. So normally what will happen, they'll be having their follow-up with the surgeons, and the surgeons will call me and say, we have a patient who's having continence issues, or a patient who's having, you know, skin issues with their radiation or things like that, or the patients self-refer. So they'll contact me and call up if they're having issues, because that's something that I discuss with them in their first appointment, that if they are having ongoing issues, if I don't know about them, I can't help them. So again, with sexual issues as well, referring them on, it's if the dialogue's not open and we don't know about it, we can't do anything about it. But Nigel will be seeing them 3 to 6 monthly, and then they get referred onto me to follow up.
Mary Jo, I tend to see patients up to 2 to 5 years as well, alongside Nigel, because I think follow-up is not just to screen for new tumours or recurrence, but it's also to look at that survivorship side of things for follow-up, you know, in terms of toxicities and trying to minimize, mitigate, and, you know, I suppose ideally prevent them. So with each visit, you'll be asking all those questions, and like for her, for instance, HRT, and seeing, you know, the menopause clinic or physio or otherwise, it's all. And we've got sexual rehabilitation centres here in private that we can refer if required for both male and female. So it's all these issues.
Yeah, I think Australia is ahead of us, at least in the United States, in terms of all those services. Serena has to leave, and there was just one question that had to do with dilators and gay men anal dilators, but we just did a seminar on that. So I'm not sure that we're going to spend a lot of time on that, because we actually just did a seminar on that. But he was wondering if benefit from doing anal dilators in between or during radiation as well. And it's a complicated topic, as I said, and we've already discussed it. Someone else was asking about immunotherapy, and I'm not sure that that's part of this group's expertise, but if you have anything add on that?
Because most tumours present so early with really good cure rates, the immunotherapy side, I think, is more targeted at those with more advanced disease or metastatic disease. And I know the new checkpoint inhibitors like pembrolizumab and various, you know, of the nivolumabs and immunotherapy agents are used successfully in that setting. When I say successful, not for cure, but improving, you know, and extending disease-free outcomes. But I can't comment more than that.
Yeah, that's okay. That wasn't exactly the focus here. I think the focus is about this team approach, and I'm very impressed with, I mean, as a patient, I would have loved it if there'd been a whole team there and someone like Ashley to talk me through it. And of course, this was a number of years ago, but I wonder if you have anything more to say, Ashley, about, because of what you do, I suspect you come across patients who don't have to advocate for themselves quite as much as people who don't have this team approach, but also who might want to become involved with advocacy. Does that come up? Or because I think that most of us, at least a long time ago, had to figure it all out ourselves.
Yeah, I think a big thing is the amount of times that the patients hold it together when they're in their appointment with the consultant. And as soon as I'm in the next room with them saying, you know, I'm here from the beginning all the way through, here's my number, you don't have to, you're not going to remember much out of today. If you're lost, you give me a call. That's when the floodgates open. So I think it's having that support and having someone who, you know, I know exactly what's going on with their treatment plan. If I, you know, don't know about it, I can get onto the clinic's notes and see exactly what's happening, and I can liaise with all of the specialists and point them in the right direction. I think that's a big thing, and with patients not feeling so alone, and especially patients who some of them aren't coming in with any close family members as that second pair of ears. They're very grateful to have someone there for them.
Do you think? Oh, sorry.
I was going to say, not only, you know, for the clinical side of things, but, you know, as, you know, just sometimes to talk them down when they're in a panic is a big thing.
Yeah. Do you also have survivors who work with the patients, or is it with you, or I mean, for people who have recovered, like Donna?
Look, nothing that I refer them through Cancer Council, which we have, which is a great organisation here. And for the colorectal cancer patients, we have Bowel Cancer Australia, and they have a peer-to-peer network, which is a thing that we can tee patients up. But it's not something that I've, you know, I don't really have the capacity to go and set anything up through any survivorship groups or anything, but there is access to a lot of things out there. But the big thing is patients, you know, being told about it. You know, you can Google things and sometimes they don't come up, whereas, you know, there's organisations that we specifically are told about at, you know, conferences and things like that, that we can then refer patients through to.
Wow, that's wonderful.
I'm just going to excuse myself if it's
I know,
okay.
I wanted to let you go. Thank you so much, Serena.
Thank you for inviting me along to participate, and enjoy the rest of the discussions.
All right,
Bye-bye.
thank you. Have a good day.
Thanks, Serena.
So we're coming close to the end. I wonder if Nigel or Ashley or anybody has some of the questions. Well, one of the things that comes up is the long-term side effects. Pauline wrote about lumbar sacral plexiopathies and rectal prolapses, and I suspect that, you know, that over time you come across some of the odd things that are related to radiation therapy, and I'm wondering how you deal with it. Do you keep? I mean, those of us like Helen who are part of support groups hear all these stories, and I'm not sure all the people that are treating patients are hearing some of the things that come up later. And I'm wondering, do you keep track of those? Do you you know, is there some way that individuals' experiences don't get lost somewhere, that it might happen again, that somebody else has some odd or not very common side effect?
Yeah, well, I'm probably slightly out of turn, but probably the most
That's a no,
common,
there's no turn.
probably the most common things would be like pelvic fractures post
Yeah.
radiotherapy,
Yeah, insufficiency fractures.
and
Yeah.
getting pelvic pain from that, which there's a few things you can do to help with that, but I think a lot of it's putting it in perspective for the patients. And I sort of somewhat jokingly say, well, you have to be alive to whinge about it. And that sounds a bit harsh and whatever, but it is reality, and the treatment is so good in terms of the number of people surviving now from anal cancer is astronomically high, and the number we get dying of recurrent or metastatic disease very, very low. So it's the risk versus benefit, and I think most patients are reasonably happy to accept it's not going to be perfect and there's going to be a few issues, but the alternatives, like having surgery in the stoma or not surviving, aren't great either.
Mhm.
And I think that's where the multidisciplinary meetings come into play as well. Sometimes we'll have weird and wonderful things that get brought to the meetings that aren't actually cancer related, that one of the surgeons is just wanting to, you know, put everything past a few colleagues and go through it in that way. So you have that, you know, collaborative approach and discussion, and, you know, all those years of experience that, you know, they can lean upon each other for those
Mhm.
things.
Yeah.
If you were to, oh, go ahead, sorry.
I was just going to make another comment once again,
Uh-huh.
speaking. I think me coming on vaginas is always fraught with danger, but certainly when I started out, Ash's role was probably sort of done de facto by stomal therapists, because there was no one else, and they would pretty much say, oh, anyone who's had chemoradiotherapy for anal or rectal cancer, the vagina's had it, it's never going to work, end of story. That's what the statistics say, so that's how it is. And, you know, particularly for young patients like Donna, not being ageist or anything, like that's very important to her, and she's put a lot of effort into rehabilitating her vagina, and I didn't ask her any details, obviously, but I think it's just a mindset thing, and having the resources there to help patients, it'll actually come out, but if you don't sort of look for it, it'll just go unnoticed, and you know, that's something that doesn't really need to happen anymore. So that's why having Ash around is so good.
Because at their first appointment with Nigel, I'm talking to them about that. So straight out being like, these are going to be the side effects that you're going to be dealing with, and you need to, you know, they're going to give you these vaginal dilators, you need to use them. You can't reverse the damage once it's done. That's when, you know, you're going to be in for a world of pain trying to rehabilitate things. But if we can prevent things, when we're getting the patients to actually use their vaginal dilators, it's at that 6-week mark when all of that peak of all of that lethargy, when, you know, you don't want to get out of bed, you don't want to do anything, and you're dragging your feet to do anything. The last thing you want to do is, you know, do vaginal dilators. But it's the, you know, when I'm at the first appointment starting to talk to them about that, and I think that's a big importance. And again, having that open dialogue and talking to patients about it, and not having these taboo subjects that, you know, seeing the patient as a whole, and that sexuality is a really important part of your health and your life. And you know, that's part of their entire
The patient must feel really heard and cared for. I mean, I just listening to you it makes me feel as if, you know, even though you might not remember what was said to you that first time, when there's this follow-up like that, it'll come back when it needs to, and you're there to help them. So that's incredible. Do either of you have any hopes for the future as we get into our last minute?
Don't really know. Well, as you said in the beginning, I'm 6 months away from completing my nurse practitioner, and I really don't know what the future holds for that as a role, whether or not the hospital is going to transition my role into being a nurse practitioner, or whether that means me leaving and going and finding something elsewhere, is you know, something that might happen. But yeah, obviously that's going to open doors for more access for patients, with having prescribing and billing rights. So that way I would be able to fund some things through the government. So that's how that works. With a nurse practitioner, you have what's called a Medicare number, so that you actually bill the government so that the patients aren't out of pocket for things.
Well, as usual, we have used up our hour, and we could probably talk for another, but this was really amazing. And thank you to Jenny McCloskey for introducing us, because she is definitely a prime mover in terms of coming up with wonderful speakers. So I appreciate you being here, and I hope that you will return for another seminar sometime. Thank you so much.